We will now begin Session 4, which deals with the laws pertaining to the dispensing of medications, as well as the approval process and regulations surrounding the medications themselves. This will include a great deal of information about the FDA. By the end of this session, a technician should be able to discuss federal and FDA laws for medications, including safety requirements, describe federal and Washington laws and rules for labeling and dispensing medications, explain Washington laws and rules for prescribing, including who may prescribe, and discuss Washington laws, rules, and standards for compounding medications. The Food and Drug Administration is responsible for regulating foods, drugs, cosmetics, and medical devices in the United States under the authority of the Food, Drug, and Cosmetic Act. We will review both the development of the FDA, the evolution of federal laws, as we see the impacts of these laws on the way medications are approved and labeled in the U.S. The Pure Food and Drug Act, also known as the Wiley Act, was passed in 1906 as the first comprehensive federal statute to assure purity and truthful labeling for foods and drugs. The act required accurate labeling in an attempt to assure that food and drugs were pure. In other words, that they contained only what should be in wholesome food or the drug as labeled, that there wasn't any adulterations or additions into the drugs that may affect this purity. Two ways in which drugs or food could violate the act are under the categories of adulteration and misbranding. Let's look into these a little bit further. Adulterated or adulteration is the presence of any added substance that could cause injury, food which is deteriorated, contains toxic substances, drugs which differ from the compendia standards, or food or drugs which are stored in unsanitary places or at improper temperatures. After 1962, this includes a failure to be produced in accordance with good manufacturing practices. Misbranded or misbranding currently includes any false or misleading statements in the labeling, which includes both the label as well as any additional statements about the product made by its manufacturer. This includes statements made in advertising. Misbranded medications also include those that have incomplete or incorrect labeling. The pharmacy may not sell or distribute any misbranded drug. An example of this that oftentimes is not thought of is if a pharmacy transfers a medication to another healthcare provider, such as a physician's office. In that case, the medication must have the complete manufacturer's information on the labeling. If it doesn't, it's considered misbranded. It is important to preserve the integrity of medications and to know with 100% certainty that they are the exact medication to be used by the practitioner receiving the agent. This is oftentimes why we see sales of medications to doctors' offices being done only as full boxes or full packages. Growing problems with modern chemicals and limits on the applicability of the Wiley Law led to the passage in 1938 of the Food, Drug, and Cosmetic Act, which has been amended several times since then. The Food, Drug, and Cosmetic Act had to define new drugs and old drugs. New drugs were the drugs that the new rules would apply to going forward, and are those drugs that are marketed after 1938. Old drugs were the drugs that were on the market prior to the Food, Drug, and Cosmetic Act and are not covered by the Food, Drug, and Cosmetic Act. These are the medications that were marketed prior to 1938. If there are changes in their formulations or labeling, however, the new rules would apply to them. Examples of old drugs include a few dosage forms of phenobarbital and a couple narcotic medications still on the market. However, the FDA believes that a few, if any of the pre-1938 drugs are still marketed in their original formulation and labeling, and thus will require a new drug application to allow them to be marketed legally. It also defined identical, related, or similar drugs. After the 1938, but before the passage of the Kefauver-Harris Amendment in 1962, whenever the FDA approved a new drug, all the existing pre-1938 drugs that were identical, related, or similar to the new drug were considered approved and were marketed without having to complete a new drug application for the product. There was also a class called generally recognized as safe. Between 1938 and 1962, many manufacturers introduced drug products into the market based on their own conclusion that the drugs were generally recognized as safe, or based on opinions from the FDA that the drugs were not new drugs. The FDA formally revoked these opinions or options as generally recognized as safe in 1968, and you see multiple amendments that have references to these, but we won't get into a great deal of detail since it's no longer permitted. So new drugs. Under the Food, Drug, and Cosmetic Act, manufacturers are required to provide proof of safety before marketing any new drugs. Manufacturers are also required to obtain pre-marketing approval of new drugs by the FDA per the Food, Drug, and Cosmetic Act. This approval is sought by filing a new drug application, or NDA, with the FDA. Prescription-only drugs. Prior to 1951, pharmacists could dispense any drug except narcotics without a prescription. As a matter of professional ethics and courtesy, however, most pharmacists required prescriptions for many drugs, although refill procedures were somewhat lax. After 1951, however, the Durham-Humphrey Amendments created a new class of drugs that could not be dispensed without a prescription. We are familiar with calling these medication legend drugs. They were called legend drugs because they were required to bear a legend on their label. The legend read, "Caution, federal law prohibits dispensing without a prescription." All existing drugs could be sold over the counter without a prescription, but new drugs that could not bear adequate labeling for safe use by consumers would now be able to be marketed with if the information was provided to the physician, and these required a prescription. The law allows for oral prescriptions and for refills as well. In 1962, additional amendments called the Kefauver-Harris Amendments were passed. These laws or these amendments were triggered by problems with thalidomide, a drug which had not actually been marketed in the U.S., but was heavily marketed in Europe because of for its anti-nausea properties. This medication was found to be very effective in treating, unfortunately, morning sickness, until it was found that it caused severe birth defects in many babies born in Europe and Canada at the time. The 1962 amendments required a whole range of changes, the first of which we'll mention is called regulations called Good Manufacturing Practices. These required significant monitoring of manufacturers' facilities and processes that we still see in effect today. It also moved control of advertising for prescription drugs from the Federal Trade Commission to the FDA. It also improved procedures and requirements for containing informed consent during clinical trials of new drugs. Lastly, and most importantly, I think, is that it required that medications provide a proof of efficacy prior to marketing. Before, with the Food, Drug, and Cosmetic Act, we saw that they had to prove safety and that the medication was pure. This is the first time we see requirements that the efficacy of a medication be proven before it is marketed. Also, the FDA had to review all the previously approved medications to make sure that they were effective in addition to being safe for all the medications that were approved since 1938 under the Food, Drug, and Cosmetic Act. To do this, the FDA had 60 panels of experts review the medications that were previously approved based on safety. They reviewed them for efficacy. And these panels ended up reviewing about 3,400 products, and over 1,000 of those were removed from the market because efficacy could not be proven. The FDA still continues to review the efficacy of medications that were marketed prior to 1938, again, not covered by the original Food, Drug, and Cosmetic Act, although we believe that few, if any, medications are still on the market from prior to this date. We've seen many amendments that we'll just call economic amendments to the Food, Drug, and Cosmetic Act since 1976. Calling them economic amendments because they largely deal with economic issues, including the marketing, patent rights, and promotion of generic drugs. Some of these acts include the Orphan Drug Act of 1983, which extended patent protection, gave tax relief to companies that developed needed drugs without significant marketing potential, kind of niche drugs that needed to be brought to the market for smaller disease states, so nobody's going to get rich in developing those medications, was the theory. The Waxman-Hatch Act of 1984, which streamlined processes for approval of generic drugs and gave extended terms of patents for certain drugs. And then the Prescription Drug Marketing Act of 1987, which controlled distribution of legend drug samples, the reselling of drugs by hospitals, and requires state licensing of wholesalers. The Food and Drug Administration Modernization Act of 1997 created significant changes in the Food, Drug, and Cosmetics Act, predominantly affecting manufacturers. One of the provisions in the Modernization Act required that the manufacturers complete studies of drugs in pediatric patients. The goal of this was to give clinicians information necessary to make clinical judgments in children. It set forth FDA authority to regulate the compounding of solutions used in PET scans. It created a system of fast-track approvals of critical drugs. It established users' fees for the processing of new drug applications. This is a provision that's still controversial to this day because some believe that it allows the FDA to profit or benefit from the processing of new drug applications, while others believe that it gives the FDA the resources necessary to adequately process the applications. It also simplified the prescription drug labels. Instead of requiring the former legend that had to be printed on all the bottles, it now requires just the simple tag RX only to be printed on the label that you now see today. This act also allowed manufacturers to disseminate information on off-label uses. We now know that manufacturers are prohibited from distributing information on off-label usage, that they must get full FDA approval for a medication for an indicated use before they speak to it. And that's because this provision of the Modernization Act has been sunsetted. A major section of the Food, Drug, Administration Modernization Act dealt with compounding pharmacy. It was invalidated by the Ninth Circuit Court, but then there were appeals by other circuit courts. So you will see different practices across the country for compounding medications depending on which interpretation of this federal statute is in place. In Washington state, it's invalidated, and it does not guide compounding of medications within our state. The Food and Drug Administration Amendments Act of 1997 was passed primarily to reauthorize the use of user fees to support the FDA new drug application review activities and allow user fees related to review and approvals of medical devices. However, Several additional reforms were included in the Act. Among the most important for pharmacists are that the FDA authority to require new safety labels in prescription drug labeling. This allowed the FDA to force manufacturers to include specific new safety information in the prescription drug labeling, rather than to negotiate the language that was to be used, which was done before. It also gave the FDA authority required for requiring post-marketing of clinical trials for approved drugs. The FDA can now insist that a manufacturer conduct additional trials on marketed drugs. This can be to assess the known or serious risks related to the use of the drug involved, to assess the signals of serious risks related to use of the drugs, and to identify unexpected serious risks when available data indicates the potential for a serious risk. It also required REMS, and the REMS is when the FDA may require manufacturers to develop a risk evaluation and mitigation strategy as a condition of approval of the new drug, or as a post-approval requirement pursuant to new safety information. We will review REMS in a short bit. The National Institutes of Health was also required to expand its clinical trials database, and manufacturers are required to provide information on all of their sponsored clinical trials. This information will be accessible online and to the general public. The FDA may require pre-broadcast review of television advertising for prescription drugs because of the Food and Drug Administration amendments of 2007. Also, manufacturers may submit direct-to-consumer advertising for prior review to the FDA. So it allows the FDA to review the direct-to-consumer ads to assure that the major statement concerning the drug's name, condition of use, side effects, and contraindications are present in a clear, conspicuous, and neutral manner. The FDA is required to develop a validated post-marketing risk identification and analysis system. And also, lastly, the pharmacist must distribute to patients a side effects statement. We will also review this in a later section. We mentioned that the FDA can require REMS as a part of the Food Drug Administration Amendments Act of 2007. The REMS requires that the manufacturer come up with a risk mitigation or risk evaluation and mitigation strategy, as we mentioned previously, which includes a step-by-step process for examining the health risks imposed by a new drug, as well as the strategies on handling such risks if they come up. You may have heard of REMS from a dispensing standpoint, as they also impact inpatient care as well, though. Risk evaluation and mitigation strategies, as required by the FDA to the manufacturers, may include the following. Risk evaluation involves assessing the health risks that potentially could be imposed by the medications at 18 months, 3 years, and 7 years after the drug has gone to the market. This is an ongoing process to monitor the health risks, since every individual responds to the drug differently, and there may be new side effects that come into play. The manufacturers might have to come up with a med guide or patient package insert that has all the basic information about the drugs for patients. This includes the indication or indications, potential side effects, how to take the medications, drug-drug and drug-food interactions, and so on. The drug manufacturers might be required to come up with a plan on how to communicate effectively with other healthcare professionals about the drug, such as its side effects, drug-drug interactions, other health risks that are now discovered, and any other medication pertinent to the care of patients in regards to the drugs. Lastly, the drug manufacturers might also be required to come up with prescribing guidelines for the physicians due to the potential health risks. The guidelines might include a plan on limiting prescribing only to those physicians who are specifically trained on the drug with its handling and administration methods, a plan on certifying providers for prescribing and dispensing that specific drug, a plan on drug administration, maybe requiring that it's only administered in certain settings or environments, a plan on drug distribution only to those patients who have some documentation that shows that the drug is needed to treat their condition, such as a lab test result to ensure safe use, or a plan to monitor each patient using the drug, and a plan to create and enroll each patient into a registry if one shall be needed. Examples of risk evaluation and mitigation strategies include iPledge and Clauseril Administration Registry enrollment. The iPledge program is a risk management program to eliminate fetal exposure to isotretinoin through a special restricted distribution program approved by the FDA. Since isotretinoin has the pregnancy category X and commonly is used by men and women of childbearing age, the drug manufacturer took part in developing this program that requires registration of all wholesalers who may distribute the agent, all healthcare professionals who may prescribe it, all pharmacies dispensing isotretinoin, and all male and female patients who get isotretinoin. iPledge has been approved by the FDA to help reduce fetal abnormality and death by making sure that all patients taking the medication use appropriate birth control, that female patients do not become pregnant once they are on isotretinoin or their partners are on isotretinoin, and those who are already pregnant do not start isotretinoin. Another example of REMS that a drug manufacturer, Novartis, took part in creating is the Clauseril Administration Registry enrollment. It is a registry developed in response to an FDA requirement for the monitoring and documenting of white blood cell counts. The FDA also expanded the requirements to include monitoring of absolute neutrophil counts. The decision was based on information provided by the Clauseril National Registry and other global Clauseril registries. With the CARE program, the agranulocytosis rate associated with Clauseril therapy is of less than 3 per 1,000 patients during the first 6 months. We will now speak about the regulation of biologic drugs and therapeutic biological products. CBER and CDER are two FDA centers that review and approve applications for drugs or devices. CBER is the Center for Biologics Evaluation and Research. It regulates allergenics, which is allergen patch testing or allergenic extracts, blood and blood products, including blood components, blood bank devices, and blood donor screening tests, tissue and tissue products, including bone, skin, corneas, ligaments, tendons, stem cells, sperm, and heart valves. CBER also regulates vaccines and tuberculin tests, xenotransplantation, which is transplantation of non-human cells, tissues, or organs into humans. One of the most common ones of these we see is the use of pig valves as a replacement for human heart valves. There's also CDER, or the Center for Drug Evaluation and Research. In addition to regulating small molecule therapeutic drugs, tests, and devices, it deals with therapeutic biologic applications for the following types of products, including monoclonal antibodies for in vivo use, cytokines, growth factors, enzymes, immune modulators, and thrombolytics, proteins intended for therapeutic use that are extracted from animals or microorganisms, including recombinant versions of these, except for clotting factors, and other non-vaccine therapeutic immune therapies. As the use of biologics evolved, There needed to be a discussion regarding biosimilar or interchangeable biologic products. These are basically the generic equivalents of biologic drugs. They are not as simple to regulate as the generic equivalents of small molecule medications because of the complicated manufacturing processes involved with the medications. The medications that are biosimilar or interchangeable biologic products are also known as follow-on biologics. Until 2010, there was no statutory route to allowing licensing of drugs that were similar or interchangeable with existing biologic products, except for a manufacturer who's a follow-on manufacturer to submit a biologics license application in place of a new drug application. In March of 2010, President Obama signed the Biologics Price Competition and Innovation Act, which amended the Public Health Service Act to provide a pathway for approval of follow-on biologicals. Applications to market biosimilars are being called 351K applications because they're allowed under Section 351K of the Public Health Services Act. Such an application must demonstrate that the medication proposed or the proposed biologic product is highly similar to the reference product, notwithstanding minor differences in clinically inactive components, and also there are no meaningful differences between the biological product and the reference product in terms of safety, purity, and potency. This approval process continues to evolve, and the FDA continues to release guidance on how the approval process will occur. We are also beginning to see certain states having their own laws relating to biosimilar products as well, but none have been passed in Washington State. Washington State has many different acts that reiterate or follow in line with other previously approved federal FDA requirements. Some examples of these laws in Washington State include the Interstate Commerce in Food and Drugs and Cosmetics, Caustic Poison Act of 1929, and the Poison Sales and Manufacturing Act. Also Poisons and Dangerous Drugs and Poison Information Centers. There's a section of our law pertaining to legend drugs called the Legend Drug Act, the Controlled Substances Act, and other controlled substance statutes, and over-the-counter medications are regulated in RCW 69.60. We will now discuss devices. The Food, Drug, and Cosmetic Act also defined devices. When the term device is used, it means an instrument, apparatus, implement, machine, contrivance, implant, in vitro reagent, or other similar related article, including any component, part, or accessory, which is recognized in the official national formulary or the United States Pharmacopoeia or any supplement to them, is intended for the diagnosis of disease or other condition, or in the cure, mitigation, treatment, or prevention of disease in a man or other animals, or intended to affect the structure or function of any part of the body of a man or animal which does not achieve its primary intended purposes through chemical action within or on the body of the man or animals, which is not dependent on being metabolized for the achievement of its primary intended purposes. This was the original definition of the law, and obviously I don't think it surprises anyone that whenever man is used, they mean human, and there have been amendments that fix this wording, also passed. Syringes and needles are not restricted under federal law, but let's look at Washington State specific restrictions. Syringe and needle sales laws in Washington State show the evolution of culture from limiting access to harm reduction and limiting bloodborne pathogen transmission. Syringes and needles sold in the state of Washington is at the discretion of the pharmacy. There is no limit on the quantity to be sold to an individual, yet the pharmacy is not required to sell syringes and needles to everybody. Technicians may sell over-the-counter syringes, but have to follow the pharmacy practices and policies on the sale. Syringes and needles should be used only for legitimate purposes. Persons over 18 years of age are allowed to carry sterile hypodermic needles and syringes to reduce blood-borne disease as a legitimate purpose. This allows for the use and sale of syringes and needles to individuals who do abuse drugs and are intending to use the syringes and needles for the use of illicit drugs, because the legitimate reason is to reduce the transmission of blood-borne disease. Public health programs and community HIV prevention programs and pharmacies are allowed to distribute syringes and needles to reduce the risk of transmission. The FDA requires structured professional labeling and prescription information to ensure the integrity of medications through the labeling. The goal of this is to eliminate any misbranded, adulterated, mislabeled, or incompletely labeled products. Furthermore, each product needs to be accompanied with a package insert that provides prescription. These are the FDA's required elements to be included on the package insert to provide information to the healthcare providers and patients. They are to guide dispensing and prescribing. They include much of the information that we're familiar to seeing in package inserts on prescription medications, for instance, that speak to the indications and usage, the correct dosage administration for those indications, the dosage forms and strengths available, contraindications, warning and precautions, adverse reactions, drug interactions, the use in specific populations or considerations in specific populations, such as elderly patients, pregnant people or pregnant women or children, drug use and dependence, overdosage, and how to treat a potential overdose, description of the medication, the clinical pharmacology, the non-clinical clinical toxicology, which is also related to overdose, clinical studies, references, and also information on how the medication is supplied, should be stored and handled, and also patient counseling information. Contraindication is a term that has a strong definition by the FDA. It is a situation in which there is clearly a health risk in using the medication, and that the risk of using the medication clearly outweighs the health benefits over the course of treatment. An example of this that we briefly mentioned before is the use of isotretinoins to treat acne in a patient that may be pregnant or is pregnant. Because the risk for teratogenic effects on the fetus is so great, it clearly outweighs the benefit of treatment in the patient at that time, and therefore the use of isotretinoins is contraindicated in pregnancy. This also provides further emphasis for the need of the pharmacist to perform a drug use evaluation to review for the presence of a contraindication in a patient, so that the medication is not dispensed to a patient if a contraindication is present. The FDA has strict requirements for what must be on the label of all medications, and over-the-counter medications are no exception to this. The package label must contain the name of the product, the name and address of the manufacturer, packager, and distributor, the net contents, the active ingredients and quantity of certain other ingredients, the name of any habit-forming drug, cautions and warnings, and adequate directions for use. Also, all of the required labeling elements must be in English, except for in Spanish-speaking territories, such as Puerto Rico, where the predominant language is other than English. They may use the predominant language for labeling medications. In this case, in Puerto Rico, The predominant language is Spanish. Drugs labeled in English that contain any representation of a foreign language must also add required elements in that language. There is a known case, called the Dr. Mom case in Washington, where a Russian cold remedy was sold in the U.S. Because the label has elements of Russian, this package must also have the required label elements be in Russian as well. Now let's talk a bit about hospital medication dispensing systems. In 2006, the FDA began to enforce a rule that medication sold to hospitals must have a barcode on the label for scanning. The barcode is to be programmed with the NDC number and be easy to readily be scanned. The medication products that would fall under this rule are hospital prescription medications, cancer and biologic medications, and over-the-counter products that are often used in a hospital setting. The goal of this rule has been to facilitate barcode scanning technologies that allow an electronic check of the medications at multiple points in the drug administration process. As we previously discussed, the FDA can set packaging requirements. One of these requirements could be the requirement for the inclusion of a patient package insert. Many products contain additional patient package inserts which are intended to be included with the dispensed prescription. Failure to dispense a package insert or medication guide, unless specifically directed to withhold it by the prescriber, is considered misbranding. However, if a patient requests a patient package insert or med guide, it must be provided even if the prescriber has directed otherwise. Two specific parts of the CFR requiring this deal with patient package inserts for oral contraceptions and for medications with estrogens. This requirement includes that oral contraceptive inserts consist of a complete insert and a brief insert. Both must be dispensed to ambulatory patients each time the drug is dispensed. In hospitals, these must be provided to the patient at the first dispensing and once every 30 days. Estrogens also require a single patient information leaflet be dispensed with each prescription and each refill. In hospitals, these must be provided to the patient with the first use of the drug and every 30 days. All the inserts or information about the medication are not to be removed, tampered, or covered. The patient can request the patient package insert at any point in time. Patient information leaflets are the supplementary information sheets that may be dispensed to a patient to further explain the counseling performed by a pharmacist. These patient information leaflets are most commonly written by third-party providers, the two largest of which are First Data Bank and Medispan. Washington requires that written information accompany prescriptions that are delivered outside the confines of the pharmacy. In other words, when a patient won't be able to be counseled, and is a national standard of practice to provide written materials to patients that expands and reinforces the information they need to properly use their drugs, which should also be communicated during patient counseling. Unfortunately, these patient information leaflets are generally written at a higher reading level than many of our patients can read and can be difficult to interpret, which is why it's best when they reiterate the important counseling that a pharmacist does. Medication guides may be required by the Food and Drug Administration. They are meant to provide basic drug information to the patients, which include indications, directions of use, side effects, and potential drug interactions. These guides are developed by the FDA and must be provided with the dispensed medication if mandated. Also, for non-mandated medications, the patient may request the guides, and then the pharmacist must provide these. Physicians may authorize to not dispense the medication guide, but the pharmacists are not required to withhold it. The medication guide can be used to replace the patient information leaflet whenever it is required to be dispensed with the medication. One example of a drug class that is to be dispensed with these medication guides is the NSAIDs, or non-steroidal anti-inflammatory drugs. The current trend appears that for most new medications that are now being approved by the FDA, medication guides are being required. Of course, with the medication guides, there have been challenges surrounding implementation of this requirement, including getting enough of the medication guides to the pharmacy in order to dispense them with every prescription. Manufacturers must place an expiration date on the container of legend drugs as well as lot numbers. As pharmacists know from their education in pharmaceutics, these dates generally reflect a time when at least 95% of the drug's labeled potency is still available and no undesirable degradation has taken place. These dates are usually assigned very conservatively by the manufacturers. If the expiration date is specified in the form of a month, day, and year, the drug may not be dispensed after that date. If the date is specified in month and year only, the drug is not to be or is considered to be expired on the last day of the month indicated. Pharmacists should not dispense a quantity of drug that cannot be used by the patient prior to the expiration date. The United States Poison Prevention Packaging Act of 1970 was enacted to prevent young children from accidentally ingesting hazardous substances commonly stored in the house. The Act requires child-resistant containers on certain household substances, all prescribed drugs, and certain over-the-counter products. The patient has the right to refuse to have their medication dispensed in the child-resistant containers, but must sign a waiver. The Act also allows the Consumer Product Safety Commission to set standards for child-resistant. These are over-the-counter products that require child-resistant containers. You will see a number of commonly used agents on this list, such as aspirin and acetaminophen and NSAIDs, or medications that could be toxic if they were to be in the hands of children, such as iron tablets. These are prescription drugs that do not require child-resistant containers. As we mentioned earlier, nitroglycerin is important to note because it must have an easy-to-open cap at the time of an emergency. A patient who suffers a heart-related condition needs to be able to open the bottle quickly in the time of an emergency. It's always been my personal belief, having suffered from migraines, that these medications should also be in non-child resistant containers, but I guess given the lack of life-threateningness of my migraines, that makes sense. Despite the joke saying that if you need to open a child-resistant container, give it to a child, there are specific requirements for these containers. The child-resistant containers must make it so that at least 90% of adults, having been shown how, can open the container within 5 minutes. Also, not more than 20% of children less than 5 years of age, having been shown how, can open the child-resistant container within 5 minutes. The container must meet USP standards for tightness and light resistance. They may not be reused. It's important to remember that because 1 in 5 children under the age of 5 can by definition open these containers, these containers really are not considered child-proof, they're child-resistant. It is better to store all medications away from children at all times. There are exemptions for the use of child-use containers and waivers that are required for child-resistant containers. Child-resistant containers are not required in the hospital setting. Also, a prescriber may write for a non-child-resistant container on the prescription, or the patient's agent may request non-child-resistant containers on all prescriptions. If the physician orders non-child resistant containers, there is no need for a waiver, but a waiver is needed if the patient or patient's agent requests the non-child resistant containers. The waiver must be written in the state of Washington, and the pharmacy must place the waiver in the patient's profile, and the waiver does not expire in Washington unless the patient requests child-resistant containers to be in use again sometime in the future. The pharmacist cannot assume the role of the patient's agent. All requests must be made directly from the patient or his or her agent. So while federal law allows for oral requests for non-child resistant containers, because Washington law is more limited, you must have the request documented in writing and document this request in the patient chart. Federal law describes the information that must be on the prescription label of every legend drug. Separately, state law also describes what should be on the label. Federal law requires the name and address of the dispenser, the serial number, the date of the statement, "Call your doctor for medical advice about side effects," and the phone number for reporting side effects to the FDA is required to be on the dispensing label according to the Food and Drug Administration. It can be placed on the sticker attached to the drug bottle or the package, be pre-printed on the vial cap, be printed on the label, a separate sheet of paper, the patient information leaflet, or the medication guide can contain this information. Regardless of where the statement is printed, it must be in bold type, big enough to catch the eyesight, and be readable by the patient or the patient's agent. According to state law, legend drug labels in community pharmacy in the state of Washington must have the following information listed. There must be complete directions for use. So if a prescriber writes "Use as directed" or UD on the prescription, the pharmacy is responsible for interpreting that and writing directions in full. Use as directed is not appropriate instructions. Generally, as directed according to written instructions provided by the prescriber has been considered appropriate if the prescriber has provided detailed information for use. The prescription must have an expiration date in which the pharmacist in Washington can assign. The expiration date cannot be later than the manufacturer's expiration date and is not limited to 1 year in Washington. The label must also have the quantity dispensed, the name and strength of the drug, the initials of the pharmacist, and a warning statement that says, "Warning, state or federal law prohibits transfer of this medication to any person other than the person for whom it is prescribed." All of the following conditions must be present to authorize a pharmacist to dispense a legend drug in the state of Washington. Each prescription should be written for a specific named patient. In order to fulfill the obligations to prevent adverse drug reactions and conduct drug use reviews, the pharmacist must be able to match the prescription order with a particular patient's profile. Some patients have requested that they be allowed to use a code name to shield their identity. This used to happen with HIV positive patients, may happen with a mentally ill patient, for example. But the Pharmacy Commission rejected the request. HIPAA requirements should be sufficient to assure confidentiality to those patients. Sometimes prescriptions are written for all members of a family or are written for one spouse who has insurance to provide drug for the uninsured spouse. These are challenges for the pharmacist as these prescriptions are invalid. Written by authorized prescribers. All states allow physicians, podiatrists, dentists, and veterinarians to prescribe legend and controlled substances. Therefore, all states honor prescriptions from these out-of-state physicians, podiatrists, dentists, and veterinarians. Other practitioners may or may not have prescriptive authority for one or more classes of drugs. Washington allows full or partial prescriptive authority to a variety of practitioners. We will discuss this authority on upcoming slides. Also in line with that, the prescription that is written must be within the scope of practice for the prescriber. For instance, it would not be appropriate to fill a prescription that a dentist wrote for birth control pills. The prescription must be issued in due course of medical practice, which means that it must be prescribed in the context of a bona fide prescriber-patient relationship. Prior to issuing a prescription, for example, the prescriber must have conducted an appropriate examination and have maintained proper records and made a professional judgment. Again, we will review this in more detail. It must be issued for legitimate medical purpose. Drugs used for non-medical purposes include stimulants for recreational use or androgens for weight training. This could include ipecac used for persons with eating disorders. Non-legitimate drug use is a greater problem with controlled substances than with other legend drugs. Nevertheless, if a pharmacist knows or should know that the drug is being used for a non-medical purpose, he or she is not authorized to dispense the product. Specific statutory prohibitions exist against prescribing, administering, or dispensing steroids or any form of autotransfusion for the purpose of manipulating hormones to increase muscle mass, strength, or weight, or to enhance athletic ability unless medically necessary, for example, runner's anemia. Steroids include anabolic steroids, androgens, human growth hormones as well. The Pharmacy Commission has listed by regulation particular drugs that constitute steroids. Off-label uses. Drugs may be prescribed for uses not included in their package insert. This is not the same as issuing a prescription for other than legitimate medical purposes. The Food, Drug, and Cosmetic Act prohibits manufacturers from promoting drugs for off-label use, but it does not restrict the practice of medicine under state law. When dispensing a prescription written for a non-FDA-approved indication, the pharmacist should be aware of the intended use and the literature supporting it. The pharmacist must distinguish between use of the drug for a condition not listed on the package insert and prescribing of doses that are outside the normal range of the drug. Resources are available to evaluate off-label uses, including the American Hospital Formulary Service and the USPDI. We will discuss requirements for legibility and tamper-proof paper and a few other requirements in greater detail on the upcoming slides. As mentioned on the previous slide, all states allow physicians, podiatrists, dentists, and veterinarians to prescribe legend and controlled substances, and therefore will honor prescriptions from these out-of-state providers. Other practitioners may or may not have prescriptive authority for one or more classes of drugs, depending on individual state law. Washington state law allows full or partial prescriptive authority to a variety of practitioners. Out-of-state prescriptions are acceptable from these listed prescribers within Washington state. Washington state allows any of the following prescribers who are licensed in any state or U.S. territory, as well as in British Columbia, to issue prescriptions for legend drugs that are valid in Washington. A note of something interesting on this: Canadian prescribers cannot issue prescriptions for controlled substances unless they are also licensed in the U.S. and registered with the DEA, however. The prescribers on this list include physicians and osteopathic physicians, dentists, podiatrists, veterinarians, nurse practitioners. This includes nurse midwives, and effective June 10th of 2010 for legend drugs, and then as of the 2013 legislative session, also applies to controlled substance prescriptions. Certified physician assistants and certified osteopathic physician's assistants can prescribe medications from any state as of the 2013 legislative session. The following healthcare providers who are authorized to prescribe medications if they're licensed in Washington include nurse anesthetists, optometrists, naturopaths, midwives with very limited scope, pharmacists under collaborative practice agreements, and physical therapists and occupational therapists who may not prescribe medications but can order and use certain legend drugs. Just to reiterate, prescriptions can be filled from out of state when they are written by physicians, podiatrists, dentists, veterinarians, nurse practitioners, and physician's assistants. This applies to all the providers who are licensed in any of the 50 states, Puerto Rico, and British Columbia. However, remember that you will only fill controlled substance prescriptions from those in British Columbia if they are locally registered and have a DEA license from the United States. Washington was the first state to allow pharmacists to prescribe through collaborative drug therapy agreements. The Pharmacy Commission has limited authority to review or approve collaborative practice agreements for pharmacists. The statute 18.64.011, Section 11, defines the practice of pharmacy to include, quote, initiating or modifying of drug therapy in accordance with written guidelines or protocols previously established and approved for his or her practice by a practitioner authorized to prescribe drugs, end quote. That key phrase, initiating or modifying drug therapy, is tantamount to saying prescribing. Since this authority is inherent in the license to practice pharmacy, it does not authorize restriction of prescriptive authority to pharmacists with particular levels of training or experience. In other words, the Pharmacy Commission could not limit this authority to just pharmacists that have obtained a PharmD degree or a certain certificate of training, etc. As long as the protocol or guideline is in writing and approved by an authorizing prescriber, the pharmacist may proceed. The board has developed rules that establish appropriate elements to be contained in the collaborative practice agreement. This is the entire list of these requirements is in WAC 246-863-100. It states that a written copy of the approved protocol must be on file with the Pharmacy Commission as well as on file in the pharmacy. The protocol must contain the identity of the authorizing practitioner and the pharmacists authorized to be stated. The guideline may authorize a pharmacist or a group of pharmacists. The board has gone back and forth on whether a group of pharmacists can be approved or it needs to be an individual pharmacist. If you are going to be involved in the writing or maintenance of a collaborative drug therapy agreement, I think it's good to get in contact with the Pharmacy Commission about it. It must have a stated time period, not to exceed 2 years, during which the protocol will be in effect, a statement of the type of prescriptive authority authorized, which includes the types of diseases, drugs, or drug categories included, the type of authority, which includes whether the drug can just be modified, or the dose maybe could be modified, or whether entire therapy could be initiated for each type. It should have a general statement of the procedures, the decision criteria, or the plan the pharmacist will follow when making therapy decisions or even referral decisions. A statement of the activities the pharmacist is to follow when exercising prescriptive authority, including documentation of decisions made and a plan for communication or feedback to the authorizing prescriber concerning decisions made. The regulation allows for documentation of the prescription in a patient chart, patient medication profile, or separate logbook. And the pharmacist who exercises prescriptive authority is responsible for obtaining informed consent to the prescribed therapy as is required of all other prescribers. As we briefly mentioned on previous slides, physical and occupational therapists cannot prescribe medications, but physical therapists may order medications and also may purchase, store, and administer the certain medications related to their practice setting. Some examples of these medications are listed on this slide. Physical therapists can also administer other drugs as prescribed by authorized healthcare practitioners for the practice of physical therapy. Occupational therapists may administer certain topical drugs as prescribed by an authorized healthcare practitioner. What becomes of his or her prescriptions when a prescriber loses his or her license or dies? Obviously, no prescriptions written after the loss of a license could be valid, and prescribers cannot issue prescriptions from the grave. However, there was a case where a deceased physician's widow continued to try to operate his practice after his death. In Washington, however, it appears that prescriptions, when written by an authorized prescriber, are valid until they legally expire, even if the prescriber subsequently loses his or her license to practice. This was found in the case listed on the slide, State v. Clausing. Because a patient can no longer obtain care from a practitioner when that practitioner is not licensed, but a prescription previously written by that practitioner is still valid, then, by extension, there is no basis to invalidate the previously issued prescription of a practitioner who dies. However, if a patient presents a new or refill prescription and there are problems with the prescription that preclude dispensing the medication until they are resolved, the pharmacist cannot consult with the dead or unlicensed prescriber and will need to locate a licensed practitioner currently caring for the patient to resolve those issues. If the patient has a new or refillable prescription that is not expired under Washington state law, and there are no problems related to the prescription that needs to be resolved in order to provide the patient with the pharmaceutical care, the pharmacist may consider the prescription valid. In every case, the best practice for a pharmacist to follow is one that assures continuity of patient care, making sure that patients remain in appropriate relationships with currently licensed practitioners, but at the same time not causing the patient to go without unnecessary medication. Prescriptions written in Washington must be legible. RCW 69-41-120 requires that written prescriptions must be legible. A separate law, RCW 69-41-010 Section 13, defines a legible prescription as one being, quote, capable of being read and understood by the pharmacist filling the prescription, or the nurse, or the practitioner implementing the medication order. A prescription must be hand-printed, typed, or electronically generated, end quote. This statute is interpreted to declare that prescriptions or drug orders written in cursive to be legally illegible. Pharmacists who fill illegible prescriptions without verifying the prescription are liable for damages caused to their patients. The best strategy for dealing with a prescription that is in cursive handwriting is to call the prescriber to verify it and indicate on the prescription the verified order. Also, we have seen issues in Washington state, while not legal, do impact practice, and that is audits that look for the fact that a prescription to be an eligible prescription must be legible. And so we've seen audit companies come in and take money back for prescriptions that were written in cursive because those are not legitimate prescriptions. So beware of this as the technician who is oftentimes the first one to be typing in a prescription. Keep this in mind to protect the pharmacy both legally and financially. In Washington state, all prescriptions that a patient may possess must be written on tamper-resistant pads for prescriptions. This is a national requirement for all Medicaid clients, but it has been broadened to include all patients carrying a prescription in Washington state. This does not apply to prescriptions that are faxed, transmitted orally, or sent electronically. Thus, if you ever receive a non-conforming prescription, check with the prescriber before dispensing. and the pharmacist may obtain a verbal prescription. If the prescription is an emergency and it is not written on tamper-resistant paper, the pharmacist has the discretion to fill the prescription, provided that they have contact with the prescriber within 72 hours to verify the prescription. If the emergency prescription is for a C2 controlled substance, the pharmacist has to verify with the prescriber and get an original copy of the prescription written on the tamper-resistant paper within 72 hours. Upon receiving a transferred prescription, the receiving pharmacist must ask the transferring pharmacist if the original prescription was on tamper-resistant paper. All prescriptions that are issued in Washington must be on the state-approved tamper-resistant paper with the state seal in the lower right-hand corner. If a prescriber is not from Washington State and the patient is not a Medicaid client, then the prescription does not have to be written on tamper-resistant paper. You can tell that the prescription paper is approved tamper-resistant by the presence of the commission seal in the bottom right-hand corner. There's an example of this on the slide, but this is not an exact replica of what you will see on the prescription pad. Also, the seal will change color when heated. For instance, if you rub your finger over the seal, it will change color. Washington State requires that there are 2 signature lines that distinguish between dispenses written or substitution permitted. Other allowances have been made for e-prescribing. You can also see the commission seal found on the previous slide should be in place of where the Washington seal is found here. I would like to take this chance to talk further about the requirement that complete directions for use are included on the prescription label. The Commission requires that the complete directions for medication usage is entered into the patient profile. As mentioned before, if UD or as directed is listed, the pharmacy technician must consult the pharmacist for specific directions for that particular medication. For example, a doctor often writes use as directed for birth control pills. The pharmacist can recommend to direct the patient to instructions on a dial pack or to take 1 tablet by mouth daily. The prescriber may have provided extensive written instructions that can be referred to in the patient's profile and on the label. Medications that may change can list 1 tablet daily or as directed by a physician. This is oftentimes used for warfarin or other anticoagulation medications. Also, as needed prescriptions should direct the patient to what the maximum dose is. For all telephoned orders or orders left on an answering machine, the pharmacist must take down all the information by writing it on a prescription paper pad. The information must include the date, time, and name of the person who called in. Recently, however, the DEA in Washington has interpreted that for controlled substance prescriptions left on message recording machines, for these prescriptions they are not promptly reduced to writing, and therefore controlled substance prescriptions may not be left on message systems in Washington State. Max prescriptions for non-controlled medications are treated like a telephone prescription. It must have the date, time, phone number, and location of the fax machine. If any of this information is missing, the pharmacist needs to call the requesting office to get the necessary pieces. If the telephone number is not provided, the pharmacy needs to fax back and request the missing information pieces. Faxes should not contain thermal paper, as that is used for the type of paper that's used for many receipts, because it does not maintain the printed material for the length required for prescriptions. Lastly, the pharmacist needs to verify unclear or suspicious orders with the prescriber. Electronic prescribing systems used by the prescriber and the pharmacy must meet the security and integrity standards. This means that the Commission has approved the system based on their inspection. Also, the pharmacy staff must sign and adhere to the security and integrity policy and procedures. The pharmacist is responsible for accuracy, validity, and authenticity of the order. The e-prescribing system must allow for communicating of generic substitution permitted or do not substitute preferences of the prescriber. The DEA has specific requirements for systems that transmit controlled substance prescriptions. It may be difficult for a pharmacist or technician to know whether a prescription came from a DEA-approved system, but it's worth checking as some systems are being slowly approved. After a drug has gone off patent, drug companies can make the same drug using the same active ingredients as long as they show bioequivalence based on dissolution or drug concentration studies. These drugs are called generics, and pharmacists can request generic substitution from the prescriber. Generic substitution allows a pharmacist to recommend a drug that is a lower cost but has the same active ingredients, dosage form, and drug movement in the body. Therapeutic substitution allows a pharmacist to dispense the drug in the same therapeutic class of the drug written. For instance, a physician wrote for atorvastatin, but the patient is better suited with simvastatin because of less side effects and drug interactions with their current medications. The pharmacist can dispense simvastatin, which is the same drug as atorvastatin. The generic drug must have the same treatment effects as the branded drug. In Washington, the pharmacist is required to select the least expensive generic drug unless either the prescriber indicated "do not interchange" by signing the dispenser's written line, or the patient indicates that they would like the brand name drug and is willing to pay cash or the higher copay, although this is not an option for Medicaid patients. For those prescription pads that come from other states which does not have the dispenser's written line, the pharmacist can substitute the medication for the cheapest generic drug provided that the prescriber did not write DAW or specifically note it in some other way. Per the Pharmacy Commission, if the prescriber did not note the DAW direction, the pharmacist may substitute only if he or she knows the rules in the state that the prescription was originally written in and has gotten authorization from the prescriber or has received the rules from the other state. All conversations, authorizations, or state rules must be documented, such as DAW or substitution permitted, as well as the name of the person who is spoken to and the date and time. This is to minimize the liability if something happens or if the Commission questions this practice when performing an inspection. Overall, the pharmacy must pass at least 60% of the savings from switching to a generic to the purchaser. The substitution done by the pharmacist must be the same to the branded drug in terms of treatment, efficacy, and dosage form. To make sure that the substitution is equal, the pharmacist can use the Orange Book to look up necessary information such as dosage or equivalence. Let's discuss the Orange Book further. The FDA put together a book that has a list of drugs that are considered generic equivalents to the branded drugs. The book lists is called the Orange Book. Between the generic and the branded drug, the FDA rated them for level of equivalence. For example, if the drug is AB between the branded and generic drug, then they can substitute the branded drug with the generic drug. If the branded drug has a rating of AB1, AB2, etc., then the generic product must also have the same rating. Some generic products have more than one rating and is used to best fit the brand. This is an example of the Orange Book ratings. For levothyroxine 25 micrograms, it has AB1, AB2, AB3, and AB4 ratings. However, not all the branded drugs have all the ratings that the generic drug has. So the pharmacist cannot make a substitution of levothyroxine 25 micrograms for all the branded drugs. The pharmacist should look at the branded drug that has the same ratings as the generic drug and make the substitution or recommendation based on that. To facilitate the education to the public and patients about the need and the requirement of pharmacies to dispense lower-cost generic medications, it is required that each pharmacy post the following notice to the public. It states, under Washington state law, an equivalent but less expensive drug may in some cases be substituted for the drug prescribed by your doctor. Such substitution, however, may only be made with the consent of your doctor. Please consult your pharmacist or physician for more information. You will see this posted at the front or at the dispensing counter of each pharmacy in Washington state. When a prescriber writes a prescription, he or she may indicate the number of refills on the prescription. Refills can be done on a monthly or biweekly basis. All refills of prescription drugs are expired after 1 year in the state of Washington, as the prescription itself is expired after 1 year. When the prescription is out of refills or is expired, a new prescription is needed. The pharmacy can fax or e-transmit a refill request, or the patient can call the doctor to request a new prescription be faxed over to the pharmacy. The doctor's office may authorize the request or deny it in a case where the patient might be due for another checkup or follow-up. This is essential to maintaining a prescriber-patient relationship required in Washington state for issuing prescription medication prescriptions. The doctor will issue a new prescription with either a new medication or a new dose, or the same medication with the same or different dose that best fits the needs of the patient. The authorization of the refill request with the number of refills is treated like a new prescription. All the refills can be dispensed until the day before the prescription is expired. For non-controlled drugs, the pharmacist can dispense a 72-hour emergency supply in the case that the prescriber cannot be reached. The pharmacist has to notify the prescriber as soon as possible that a 72-hour day supply has been given to the patient. Refills are in accordance to the directions of use, and the patient is monitored for overuse. Prescribers cannot allow a nurse or their staff to authorize refills because it is not safe for the patients due to the lack of treatment monitoring. This is supported by the National Committee for Quality Assurance. In Washington state, it does seem that if a clear notation regarding refills is made by the prescriber, then a nurse can carry out the refills in that case. According to the Washington State Nursing Quality Assurance Commission, refill request authorization is outside the scope of nursing practice. This is still an area where we see a need for improvement in practice. A therapeutic interchange program is required using a preferred drug list in all state-funded programs, including Medicaid, Labor and Industry, and the Uniform Medical Plan for state employees. The Washington State Healthcare Authority administers the program, which is entitled RX Washington. The current preferred drug list is updated frequently on the RX Washington website. The preferred drug list on rxwashington.com provides listings of medications that are more affordable while maintaining the same level of effectiveness in treating disease. This list of medications are used by the state paid drug benefits plan in order to minimize drug costs, but at the same time are able to support effective medical treatment for the people. The pharmacist can pick out medications from this list and use that to substitute on a more expensive branded drug. Endorsing prescribers who indicate dispenses written for a non-preferred drug list product won't need a prior authorization. A non-endorsing prescriber who prescribes a non-preferred drug will need to get prior authorization. Refills of antipsychotics, antidepressants,
chemotherapy, HIV drugs, hepatitis C drugs, and drugs for autoimmune diseases do not follow these guidelines. However, when a pharmacist makes a change based on the preferred drug list, they must notify the prescriber of the drug and dose being dispensed. When the prescriber writes a prescription, he or she can indicate the number of refills. Refills can be done on a monthly or bi-weekly basis. However, all refills for prescription drugs are expired after 1 year in the state of Washington, and the prescription itself is expired after 1 year. When the prescription is out of refills or is expired, a new prescription is needed. The pharmacy can fax or e-transmit a refill request, or the patient can call the doctor to request a new prescription be faxed over to the pharmacy. The doctor's office may authorize the request or deny it because the patient might be due for a checkup, a requirement to maintain the prescriber-patient relationship. The doctor will issue a new prescription with either a new medication and a new dose, or the same medication with the same or different dose that best fits the patient. The authorization of the refill request with the number of refills is treated as a new prescription. All the refills can be dispensed until the day before the prescription is expired. For non-controlled drugs, the pharmacist can dispense a 72-hour supply in the case that the prescriber cannot be reached. The pharmacist has to notify the prescriber as soon as possible that a 72-hour supply has been given to the patient. Refills are in accordance to the directions for use, and the patient is monitored for overuse. Prescribers cannot allow a nurse or their staff to authorize refills because this is not safe for patients due to the lack of treatment monitoring. This is supported by the National Committee for Quality Assurance. If clear notation regarding the refills is made by the prescriber, then a nurse can carry out the refills, according to the Nursing Commission in Washington State. Refill request authorization is outside of the scope of nursing practice, however, in general, and so this can see
Pharmacists may administer and prescribe medications via bodily orifices or injection, or if there is no special certification needed. This is because the scope of practice of pharmacy lists administration. However, there must be a collaborative practice agreement in place between the prescriber and the pharmacist if the pharmacist is to give any other drugs without a prescription. Again, we will later discuss the ability of the pharmacist to prescribe medications. On a related note, there is a law that impacts administration of drugs to pregnant women and children under 3 years of age by all healthcare providers in Washington. Any drug or vaccine administered to pregnant women and small children should contain less than 0.5 micrograms of mercury per half a ml dose, or 1 microgram of mercury per half ml dose for flu shots. This law often needs to be waived in special situations in Washington by the Secretary of Health. No prescription from a physician will override this law or permit administration of preservative-containing vaccine to these groups. Note, though, that there is no evidence for this law, that there has been no data to show that mercury from vaccines is not safe for patients. This law was passed because of untrue and disproven concerns of thimerosal in vaccines. Also, most all vaccines in the United States, with the exception of flu vaccine and Japanese encephalitis vaccine for children under 6 years of age, already do not contain thimerosal or these levels of mercury. So most all vaccines given to kids already meet these requirements. These are the healthcare providers in Washington who are permitted to administer certain medications. It is noteworthy that healthcare assistants and facility personnel are to aid with medication administrations, either to aid a nurse or aid an individual patient in giving themselves medication.
We will now discuss the return or exchange of drugs from consumers. Generally, pharmacies may not accept returns or exchanges of drugs, items of personal hygiene, or sickroom supplies after the items have left the pharmacy. The FDA has issued a compliance policy guide in 1980 which stated that a pharmacist should not return drug products to his stock once they have been out of his possession. It goes on to say that the pharmacist or doctor dispensing the drug is legally responsible for all hazards of contamination or adulteration that may arise, should he mix return portions of drugs into his shelf stocks. Consumers may not return recalled drugs to pharmacies, but may send them directly to the recalling manufacturer or reverse distributor authorized to receive them. Exceptions to this rule are if a unit dose package or full, partial, multiple dose medication cards may be accepted from hospitals or long-term care facilities, but only if the pharmacist can determine that the package is intact, and the pharmacist also determines that the unit dose package or multiple dose card meets the USP standards for storage, including temperature, light sensitivity, and chemical and physical stability. For this requirement, the board investigators have recently challenged that the packages meet the USP standards and that the containers sufficiently protect the medications. The pharmacist may also, at their discretion, consider allowing a returned medication if the drug has been stored in such a manner as to prevent contamination by means that would affect the efficacy or toxicity of the drug within that hospital or long-term care facility, or if the pharmacist must know that the drug has always been under the control of a third party trained and knowledgeable in storage and administration of medications, if the labeling or packaging has not been altered or defaced so that the identity of the drug, its potency, lot number, or expiration date is retrievable, if the drug has been pre-packaged, if it was not mixed with other drugs of different lot numbers or expiration dates, unless the specific lot numbers were retrievable and the expiration dates may accompany the drug. If the drug is extemporaneously packaged, it should not be mixed with other drugs of different expiration dates, unless the earliest expiration date appears on the label. Durable medical equipment is also excluded from this law, as it is allowed to return mobility aids and wheelchairs if appropriate.
The United States Pharmacopoeia has developed guidelines on pharmacy compounding found in Chapter 795. These chapters apply to non-sterile preparations, and it is recommended that expiration dating be done on non-aqueous liquids and solids for 6 months, or 25% of the manufacturer's proposed expiration date if the product is made from another manufactured product. If the expiration date is no longer than 6 months, if the U.S. Pharmacopoeia or National Formulary Certified ingredients are used. Aqueous solution should be dated 14 days until the expiration and should be stored in a cold place. All other compounds should have 30-day expiration dates, or to be outdated after the intended duration. Also included at the bottom of the slide are resources to help you if you work in an area that compounds medications. For compounded products, the following must be on the label: the name of the compound, the ID number created by the facility or pharmacy, the expiration date, initials of the compounder, storage directions, a warning statement, and any other information required by the state. If you ever enter into a compounding pharmacy for practice, you will need to gain a great deal more practice and experience with these concepts. Other labeling recommendations based on the International Academy of Compounding Pharmacists can include the label, "This medication was specially compounded." Other items can be included on the label include the patient and prescriber names, the label, address, and phone number of the compounding pharmacy, the prescription and lot number, the medication strength, name, quantity, directions for use, the date filled, an expiration date, storage instructions, and any other instructions pertaining to the medication. It's important that all labeling requirements are met on dispensed compounded medications to ensure the drug's quality and safe use. Compounding pharmacies can be accredited by the Pharmacy Compounding Accreditation Board, or PCAB, which was formed by many national pharmacy organizations. PCAB sets out compounding standards and the rules to enforce and regulate those standards. Certification is voluntary. PCAB also evaluates whether compounding pharmacies comply with these standards and rules that it has set. They can certify pharmacies in non-sterile and both basic and complex compounding, low, medium, and high-risk sterile compounding. The safety of compounding pharmacy is being scrutinized more closely, and more pharmacies may face pressure or requirements to be certified. The Good Compounding Practices in Washington list requirements. One is that there is documentation that the physician and patient have agreed to use a compounded product in place of a commercially available product. Also, the pharmacist can use the USP or National Formulary Certified Drug Sources as a first choice. If this is not an option, the pharmacist can choose a source based on their professional judgment. In addition, the pharmacy shall compound in limited amounts based on past orders to meet current number of refills. The pharmacy may sell the compounded product to the prescriber, provided that the drug is not expired, for administration. However, when a compounded medication is made for a particular prescription, the pharmacy may not resell the remaining amount to any patient. Also, the doctor's office cannot sell the remaining amount of the drug that was administered. These laws will probably be evolving a great deal over the next year or two, as the Board of Pharmacy has just opened up the rules-making processes for compounded drugs to reflect current concerns over large compounders across the United States and the safety of their products. This describes pharmacists and ancillary personnel in compounding. The pharmacists are to inspect the drugs, equipment, and assess the accuracy of the product. This may include overseeing techniques of the compounding personnel and to enforce all rules and regulations of compounding pharmacy. The pharmacist is also to ensure that the compounding business is up to standards set forth by the Commission and the United States Pharmacopoeia. They must keep up to date with all their continuing education in compounding pharmacy. The ancillary personnel in practicing compounding pharmacy has to meet clothing and gowning standards. Those who have a cut or are sick must be excluded from the compounding area due to the risk of contaminating the compounded products and equipment. We discussed USP 795 for non-sterile product guidelines. Sterile compounding is guided by the USP Chapter 797. This chapter sets out compounding standards such as the setup of facilities, the training of personnel, room environmental control, the lighting, the storage of bulk and compounded products, and more. In order to ensure a high quality of compounded products, the sterile compounders should follow the guidelines in USP chapters. Also, sterile compounding overall has to follow the rules for home IV pharmacies as in compounding sterile IV medications. We reviewed the requirements for parenteral pharmacies in an earlier session. The FDA has charged the State Board of Pharmacies with enforcing these rules. We previously mentioned PCAB. According to the Pharmacy Accreditation Board, compounding is the preparation of drug based on practitioner, pharmacist, and a patient relationship. Compounded products may be dispensed for office use, but may not be resold by the practitioners. The pharmacist may compound the drug product based on past orders or based on routine patterns. However, the product is to be different from the commercially available products. The prescriber and the patient must know that the product being dispensed is customized based on the patient's needs. Any advertising should include only scientifically based claims. More information on compounding principles can be found on www.pcab.info. Prescription drug sales are to be distributed to practitioners or hospitals per the prescriber's request. There should be no charge for samples, and clinics can take some to distribute to providers and patients. However, community pharmacies cannot hold any samples from pharmaceutical companies. The FDA has developed guidance for free clinic distribution of samples. With accommodation sales and transfers, pharmacies can transfer Legend drugs to other pharmacies or prescribers without registering as a wholesaler. However, the transfer cannot be more than 5% of the total sales in the previous 12 months. All documentations must be retained for all transfers and must be available upon request for the commission at the time of the pharmacy inspection. The pharmacy should not repackage the medications to be transferred, as doing so can alter the integrity of the drugs and the authenticity of the label, which can lead to concerns of misbranding and/or adulterations of the medications. Importation of drugs from outside the U.S. can only be done by a company that is registered with the FDA and is licensed in the U.S. This system helps to track drugs that are being trafficked in and out of the U.S. and thus to ensure legitimacy, authenticity, and safety for the consumers. Also, drugs that are imported from outside the U.S. can violate FDA laws because they are unapproved medications, possibly labeled incorrectly, or were possibly dispensed without a prescription. The FDA might overlook and take no actions on drugs that are carried for personal use and are being brought to the U.S. in small amounts. For example, less than a 90-day supply by a traveler. With this said, it does not make it legal by the FDA or DEA for importation of controlled substances into the U.S. by individuals. This now concludes Session 4.